So the topic I'm going to discuss now is onchocerciasis. So I'm going to start with the introduction here. Onchocerciasis, which affects the eyes and skin, is the second most common cause of infectious blindness in the world. It is endemic in areas of Africa and other regions, and disease is particularly severe in savanna regions, where in some areas more than 50% of older adults are blind from the condition. Chronic onchocerciasis shortens the lifespan by reducing resistance to other diseases. The parasite helminth Onchocerca volvulus is causative. The vector is the Similium blackfly, which breeds in the fast-flowing water, hence the colloquial term river blindness. The life cycle of Onchocerca volvulus is illustrated in this diagram. The blackfly, it bites to obtain blood, and larvae are transmitted when it bites. The larvae then migrate to the skin and to the subcutaneous sites to form onchocercomas, as it is portrayed in the diagram. This is one of the potential sites, and these microfilari are produced by the adult worm. Degenerating microfilari excite an intense inflammatory reaction, accounting for most of the clinical manifestation of disease. And the Rickettsia wolbachia lives symbiotically in adult worm and microfilari and is important for microfilarial production. Diagnosis is done later on. However, as you can see, this nodule here is one of the presentation, and then it can cause itching, leopard skin, blindness in the later older adults, and it can cause a nodding syndrome, which is a form of a childhood epilepsy. And this diagram illustrates a lot of the symptoms which are caused by this parasite. Now, diagnosis is by skin snip biopsy, of course, serology, tear or urine antigen detection, which is oncodipstick, or by the PCR of the lesion fluid. Systemic features are principally dermatological and include pruritus, maculopapular rash called onchodermatitis, as it is illustrated in the figure here, and it involves the buttocks and the extremities and areas of hypo and hyperpigmentations on the shins, which is called leopard skin, as it is illustrated in this figure. It looks a little bit like vitiligo, but it's not. Scratching of the itchy areas leads to lichenification, like thickening of the skin, and this here is an onchocercomata, which are non-tender subcutaneous nodules that enclose in them 2 to 3 adult worms. Severe lymphadenopathy can occur with secondary lymphedema, and eosinophilia is typical as of any parasitic infection. Important to us and very relevant to us are the clinical features. In eye, live microfilari may be seen in the cornea, vitreous, and suspended in the anterior chamber after the patient has postured face down for a few minutes, followed by immediate slit lamp examination. Anterior uveitis is an early feature. Pear-shaped pupillary dilatation may be seen and is due to posterior synecdoche. Keratitis is punctate, and snowflake opacities affect a third of the patients and consist of infiltrate surrounding dead microfilary. Initially, the lesions that occur are at 3 and 9 o'clock, and at this site here and here, and later on they slowly progress and cause sclerosing keratitis, which eventually involves the entire cornea. In the beginning, it only involves interior 1/3 of the stroma, but as you can see in this figure, it is almost involving the whole cornea, and visual access is involved. So that is unfortunate. Chorioretinitis is usually bilateral and predominantly involves the temporal fundus. However, it spares the macular area until late. Unlike the figures here, it is involving the macular area. The chorioretinal atrophy is actually widespread, and choroidal sclerosis and atrophy, it can ensue. A perpetuating autoimmune response is hypothesized for progressing longer-term chorioretinopathy that may persist after control of infection. Optic neuritis, if it occurs, it usually is acute. In the second figure, you can see that the whole area, even adjacent to the disc, it is involved, and there is widespread chorioretinopathy. Treatment. First, we are going to discuss this treatment that is very specific to the disease. Ivermectin, supplied in many countries by Merck at no charge, kills microfilary but not the adult worms, and is given at least annually for many years. It has been effective in substantially reducing transmission rates and morbidity, and no recent new cases have been reported in many communities. Ivermectin occasionally precipitates inflammation, so prophylactically prednisolone may be considered in patients with visible AC microfilary. Ivermectin may cause toxic encephalopathy in patients with lower infection. Moxidectin is actually quite newer drug that may be superior to ivermectin. Doxycycline is a very common drug. 100 to 200 milligram per day for 6 weeks targets Wolbachia, which is actually the rickettsia, which lives symbiotically with microfilary and adult worms, and it indirectly prevents microfilarial embryogenesis and substantially reduces the numbers for an extended period. It also has some effect on adult worms and may be a useful adjunct to ivermectin or moxidectin. Now, suramine, as opposed to ivermectin, is effective against adult worm, but it is given intravenously. In the end, steroids or favorite drug. Anterior uveitis is responsive to it. So we'll conclude our topic of cysticercosis. Sorry, we'll conclude our topic of onchocerciasis here, and it's a very important topic because 50% of infective blindness, and it is the second most common cause of infective blindness in the world. So we should be able to detect it and treat it very effectively. It comes with its very own specific signs and symptoms. So I don't think that it should be mistaken for any other disease, and should be very clearly understood in the clinics. So thank you all for listening to this lecture. If you like it, please subscribe and like.